For years, if you needed a vascular procedure, well, you automatically pictured a hospital, right?
hmm Standard thinking.
But the landscape is, it's really changing. Increasingly, these interventions are happening in outpatient vascular centers, office-based labs or OBLs.
That's right.
It might surprise you, actually, just how much this field is evolving. It's offering a really different approach to care.
Exactly. And that's precisely what we're diving into today, the world of these outpatient vascular centers.
Okay.
Our guide for this deep dive is Chapter 198 of Rutherford's Vascular Surgery and Endovascular Therapy. So think of it as well, a pretty comprehensive overview of this growing area in medicine.
So this isn't just about convenience, then. It sounds like a fundamental shift in how care is delivered.
It really is.
We want to unpack why these centers are emerging, what makes them tick, what makes them successful, and, ultimately what this means for you, the listener, in terms of treatment options and maybe costs, too.
Definitely cost.
Consider this your fast track, maybe, to understanding this pretty fascinating evolution in healthcare.
Precisely. Yeah, this chapter gives us a really detailed look at how these outpatient centers are developed and operated successfully.
Right.
Our mission today is basically to pull out the most important insights, why they've become a real option, how they function day to day, and the kinds of procedures you're likely to find being performed in these settings.
Okay, let's unpack this then. The idea of having potentially, complex vascular procedures outside of a hospital, that feels like a pretty significant leap, doesn't it?
Oh, absolutely.
Where did this all start?
Well, if you go back a bit, endovascular procedures were, almost exclusively done in hospitals, often required an overnight stay too.
Right, standard procedure.
Exactly. But over time, we saw a move towards same-day discharge becoming more common. But the real turning point, I think, came as the safety and effectiveness of these procedures became really well established, within the hospital environment first.
So once that foundation of safety was there, what really pushed the shift towards these, dedicated office settings? Was it just about saving money?
Cost efficiency was definitely a major factor, yeah. And studies have shown these settings can be more cost-effective.
Okay.
But it was also about proving clinical efficacy.
Yeah.
Demonstrating that these procedures could be performed just as safely and effectively in an outpatient setting.
Right. Proving it works outside the hospital walls.
Exactly. And a key moment, really, was the Deficit Reduction Act of 2005.
Ah, yeah.
This piece of legislation allowed CMS, Centers for Medicare and Medicaid Services, to actually reimburse for specific endovascular procedures performed in office-based labs.
Huge deal.
Oh, massive.
Right.
That single piece of legislation, well, it fundamentally reshaped how these procedures are delivered and paid for. It opened the door for wider access outside traditional hospitals.
And I guess other insurers jumped on board after that.
Yeah, naturally, other insurers followed suit.
Okay, that's a crucial piece of the puzzle then. Now, when we talk about outpatient centers, are they all basically the same? The chapter mentioned a few different kinds.
No, that's a good point. It's important to make a distinction. You have hospital-associated outpatient centers, right? Then you've got ambulatory surgery centers, ASCs.
Okay.
And then the office-based endovascular centers, or OECs and OBLs. Those are our main focus today.
Right, the OECs.
And while they're all outpatient options, they operate under different rules, different regulations, different payment models.
So ASCs versus OECs, what's the key difference for, say, a patient?
Well, both offer care outside a traditional hospital, sure. But OECs often mean a more direct connection to your specialist, maybe in a setting really tailored to specific procedures. ASCs might handle a broader range of surgeries, and they generally have more stringent facility requirements.
Right, okay. And the way they get paid differs too. You mentioned that the chapter touched on that. Outpatient prospective payment for the hospital ones, a facility fee for ASCs. What about OBCs?
For OECs, Medicare and other insurers typically pay what's called a non-facility or global rate.
Global rate.
Yeah, it basically means the center gets a single payment that covers both the doctor's work and the equipment, the supplies used. Unlike hospitals where those might be billed separately.
Yeah, I see.
And the core definition of an OEC that's really important here is that it's essentially a procedural suite located within a doctor's office. It's an extension of their regular practice.
Huh. Interesting. So while we're focusing on vascular stuff today, the chapter suggested these basic ideas, they could apply elsewhere in medicine too.
Oh, absolutely. While our deep dive is into vascular OECs, the fundamental concepts behind setting up and running an efficient, compliant, office-based procedural center Yeah, they have broader relevance across various fields.
Okay, let's really zero in on OECs versus ASCs for a second. Table 198.1 in the chapter laid out some key differences. What really stands out to you there?
Well, what's fascinating is the contrast in several key areas.
Yeah.
Payment methods, like we just said, they're different.
Right.
But also the scope of procedures that are typically allowed. That varies. The chapter uses the example of coronary artery angioplasty.
Ah, heart procedures.
Yeah, which can be done in an ASC, but generally not in an OEC. Physician usage is different too. ASCs can be used by lots of independent doctors, right?
Mm-hmm.
Whereas OECs are usually tied to the specific physicians who practice right there in that office.
Makes sense.
And then you look at ownership, licensing, the capital investment needed. Across the board, there are notable distinctions. ASCs generally need a bigger upfront investment, larger facilities, and they're subject to much more rigorous federal and state licensing.
It sounds like OECs offer maybe a more streamlined model in some ways, but perhaps with less federal oversight, which leads us straight to regulations. That sounds absolutely critical for anyone running an OEC.
It is. It's absolutely critical. The chapter really emphasizes that unlike ASCs, these office-based labs don't have this comprehensive set of federal regulations dictating their day-to-day operations.
So it's more state level.
Exactly. The primary oversight really happens at the state level.
Hmm.
Table 198.1 underscores this, noting compliance with state laws as a key thing for OECs.
Okay, so what are the main areas states are typically looking at when regulating OECs?
The big three are usually anesthesia, radiology, and OSHA.
OSHA, right, workplace safety.
Yep, Occupational Safety and Health Administration. For anesthesia, the level of regulation often depends on how deep the sedation is.
Okay.
Many states don't require an anesthesiologist present for, say, minimal to moderate sedation. However, some states, like New York is mentioned in the chapter,
Right.
they might require anesthesiology personnel if moderate to severe sedation is needed for the procedures.
And radiology regs. I imagine there are definite concerns about radiation exposure in these office settings.
Exactly. And state regulations on radiology can differ quite a bit. Not every state mandates lead lining for the procedure room if they're using a C-arm, that mobile x-ray machine. Some states also require that only certified radiology techs can operate that equipment. So it's absolutely crucial for OECs to know and follow their specific state laws about C-arm inspections, lead lining, staff qualifications, training,
All that stuff.
all that stuff. Plus rules about lead aprons, making sure they're intact, and mandatory dosimeters for monitoring staff radiation exposure.
And OSHA. That's about keeping the staff safe, the working environment safe for everyone, right?
Precisely. Diligent OSHA compliance is essential. This means having proper safety training for everyone, well-defined policies for different scenarios, employee handbooks outlining safety protocols, and the right procedures for recording any workplace incidents, like needle stick injuries, for example.
Right.
The chapter even points you to the OSHA website for all the detailed requirements.
Okay, so navigating this regulatory maze is clearly a huge piece of the puzzle. What other key components does the chapter identify as being crucial for a successful outpatient vascular center?
Well, the chapter breaks it down into a few essential areas. First, you need the basic patient care infrastructure, an office for patients, basically.
Right.
This means having standard exam rooms for consultations and follow-ups, plus enough qualified nursing staff for direct patient care.
Makes sense. It's still a doctor's office at heart, just with added capabilities. What else is essential?
A non-invasive vascular lab is absolutely crucial.
The diagnostic side.
Exactly. This
Yeah.
lab provides essential diagnostic support for both the general practice and the endovascular lab itself. The chapter lists some required equipment like a good ultrasound machine, capable of imaging veins, arteries, aorta, carotids.
Mm-hmm.
And importantly, that same ultrasound can often be used to guide the needle for vessel access during the actual procedures.
Okay, so good imaging is paramount. What other gear is needed in that non-invasive lab?
A Doppler machine is necessary.
Hmm.
That's for getting blood flow waveforms and measuring ankle and toe pressures, vital for assessing circulation in the legs and feet.
All right.
And for specific conditions like Raynaud's or, say, dialysis access steel syndromes, you need specialized photoplethysmography equipment for looking at the tiny digital vessels.
Okay.
And the chapter strongly emphasizes getting this non-invasive lab certified, either by the IAC Intersocietal Accreditation Commission or the ACR, the American College of Radiology.
Why is that certification so important?
It basically demonstrates a commitment to quality, to standardized testing. It shows you're meeting certain benchmarks.
Okay, so that covers the diagnostics. Now, what about the endovascular lab itself, the room where the actual procedures happen?
Right, this is where the interventions take place. The chapter points out that theoretically, almost all the percutaneous endovascular procedures done in hospitals could be safely done in an office-based lab.
Really? Almost all?
Theoretically, yes. But, and this is the big but, because resources in an OEC are typically more limited than in a full hospital. Patient selection is absolutely critical. You have to choose the right patients to ensure the best outcomes.
So what specific things would make someone not a good candidate for an OEC procedure?
The chapter outlines some absolute contraindications, like if someone definitely needs general anesthesia,
Okay.
or if they have significant underlying medical conditions, comorbidities, that really necessitate a hospital admission anyway.
All right, too high risk.
Exactly. Or if you anticipate they'll need a prolonged period of observation after the procedure, or if they have a severe allergy to the contrast dye used in imaging. Those are generally no-goes for an OEC.
What about relative contraindications, things that make it less ideal?
Yeah, things like patient weight may be over 400 pounds, could be challenging for the equipment or staff, or someone with a very low pain tolerance, if only conscious sedation is available, might not be the best fit.
That all makes logical sense. Are there specific types of procedures that are generally just not done or maybe not allowed in OECs?
Yes, definitely. The chapter is explicit that complex procedures like endovascular repair of aortic aneurysms, EVAR, and carotid artery stenting, those are not typically performed in the office-based setting.
And not reimbursed either.
Correct. Not reimbursed by payers in that setting. There's a mention of a pilot study looking at doing some infrarenal aneurysm repairs in OECs. But the authors strongly caution against that for now. They say, until larger studies confirm the long-term safety and effectiveness, those procedures really should stay within the hospital setting.
Right. So it highlights that OECs are great for many things, but the really complex or high-risk stuff still needs full hospital resources.
Precisely.
Okay, so we've covered what generally can't be done. Let's move to what is commonly done. The chapter outlines types of procedures performed, starting with hemodialysis access-related procedures. That seems like a big area, right? Keeping dialysis access working.
It is. It's a significant part of many OEC practices. The chapter actually points to another chapter, 199, for more detail, but it gives a good overview here.
Okay.
The main emphasis is really on maintaining the function of existing access fistulas, grafts, and actively trying to avoid placing catheters whenever possible.
Because of infection risk.
Exactly. Higher risk of infections, and they can also cause narrowing, stenosis, in the central veins later on. But, in urgent situations, if a patient needs dialysis now and doesn't have a working access, catheters can be safely placed in the office.
Okay. And trained mid-levels can sometimes remove them too.
Yeah. Appropriately trained mid-level providers can often be authorized to remove those temporary catheters.
So what kind of interventions are we talking about for these existing accesses? When do you need to intervene?
The chapter lists several key reasons for doing a fistulogram, that's the X-ray, to look at the access. Things like a noticeable drop in blood flow, increased pressure or bleeding at the site, maybe ultrasound shows a narrowing, difficulty cannulating the vein for dialysis, increased recirculation of blood, or just dialysis isn't clearing waste as well.
So specific problems, not just routine checks.
Right. The chapter stresses that routine scheduled fistulograms generally aren't indicated. But if a stenosis is found, it can often be treated effectively right then and there with angioplasty using a balloon to widen it. And sometimes bare metal or covered stents might be needed for extra support, especially if the vessel tends to spring back after ballooning. That's called elastic recoil.
What about other technologies like atherectomy removing plaque for dialysis access?
The chapter specifically points out that laser atherectomy for treating blockages within existing dialysis access stents is not currently FDA approved. So that shouldn't be done in an OEC.
Okay, good to know.
But other things like coil embolization can be used. That's where you block off small side branches that are maybe stealing blood flow away from the main access.
Fixing the plumbing.
Kind of, yeah.
Yeah.
And balloon-assisted maturation, or BAM, helping new fistulas develop, that's mentioned. But there isn't a specific reimbursement code for it right now.
What about IVUS, intravascular ultrasound?
Yeah, IVUS can be really valuable. It uses ultrasound from inside the vessel to get detailed images. It's great for accurately assessing how bad a stenosis is and choosing the right size balloon or stent.
And what if the access clots off completely? That sounds like an emergency for the patient.
It is indeed urgent. Declining a thrombosed access can often be done percutaneously in the OVC. using medications to dissolve the clot or special mechanical devices to remove it.
Okay.
But the crucial next step, after clearing the clot, is finding and treating the underlying stenosis that probably caused it to clot in the first place. Usually that means angioplasty.
Right, fix the root cause.
Exactly. The chapter also mentions treating central venous stenosis narrowings higher up, often from old catheters or pacemakers, and also arterial inflow problems, sometimes using stents placed either backwards through the access or forwards from the groin.
Okay, that's a really thorough look at dialysis access work in OECs. Let's switch gears to peripheral arterial procedures. What kinds of things are being done for blockages in the legs and other arteries in these labs?
Well, diagnostic arteriography is common. That's the X-ray with contrast dye to visualize the arteries.
Right.
It can be done for lots of reasons, evaluating carotid disease, renal artery stenosis, poor blood flow ischemia in the arms or legs, aneurysms, even blockages in the gut arteries, visceral ischemia. Interestingly, you can generally get reimbursed for a diagnostic arteriogram for almost any artery except the coronaries, if it's done in an OEC.
But if you did the same thing in an ASC?
Then it is typically reimbursable for the coronaries too. Bit of a quirk in the system.
Huh. And how do they usually access the arteries for these procedures?
The femoral artery in the groin is the most common route, but the chapter also mentions brachial access in the arm, radial in the wrist, even tibial down in the lower leg, especially if the usual routes aren't good options.
Okay.
And before any procedure, it's important to check kidney function because of the contrast dye.
Right, the dye can be tough on kidneys.
Yeah, so patients with kidney issues might need extra hydration or maybe even CO2 angiography using carbon dioxide gas instead of the usual dye.
And closure devices after. Do they help?
They can be used at the access site. Studies haven't really shown they significantly reduce major bleeding compared to just holding pressure, but they might shorten the time until the patient can go home. So maybe more for convenience.
Got it. And what about actually fixing the blockages found in peripheral arteries?
Well, for visceral and renal arteries supplying the gut and kidneys, angioplasty and stenting can be done effectively in OECs for the right reasons, to improve blood flow.
Okay.
For the iliac arteries, the big ones in the pelvis, angioplasty and stenting have shown pretty good long-term results. Atherectomy in the iliacs, though, the chapter notes it hasn't consistently proven better than angioplasty alone and isn't always reimbursed there.
And you mentioned carotid stenting is generally out for OECs.
Right, not reimbursed. And aortic angioplasty is rarely needed or done in this setting.
So what about the really common stuff people get in their legs? Blockages in the thigh, behind the knee, down in the calf arteries.
Yeah, the SFA, popliteal, and tibial arteries. Interventions there are probably some of the most frequent procedures done in outpatient vascular centers.
Makes sense.
The chapter stresses you need good documentation first, showing medical management was tried, results from the non-invasive lab, justifying why intervention is needed. Then angioplasty, stenting, and atherectomy are all used to improve blood flow. There was even a study mentioned showing atherectomy works well, specifically in the arteries below the groin.
And new technologies are coming in, too.
Definitely. Increasing use of drug-eluting balloons, new stent designs that release medication over time, drug-coated stents, all aimed at trying to keep the arteries open longer.
What if you can't get through a blockage from the groin?
That's where a retrograde tibial approach comes in. You can sometimes access an artery down in the lower leg and go upwards to cross the blockage, especially if the groin access is difficult or blocked itself.
Clever.
Yeah. And finally, the chapter mentions treating blockages in the arm arteries too, subclavian, axillary, brachial, etc., with angioplasty and stenting when needed.
Okay, that's a great overview of the arterial side. What about veins? Are OECs treating vein problems too?
Yes, absolutely. Venous issues are a big part of it too. Stenosis, or narrowing, in the big veins in the pelvis, and upper leg, the iliac and femoral veins.
Often from old clots, right? Or compression.
Exactly. Often post-thrombotic, or maybe May-Thurner syndrome, where an artery compresses the vein. These can be diagnosed using venography, the vein X-ray, and especially IVUS, intravascular ultrasound.
And treated how?
Usually with angioplasty and stenting. Studies have shown good long-term results for keeping these veins open with stents placed in OECs, and importantly, giving patients relief from symptoms like leg swelling and pain.
And it's safe to do this in an OEC.
Yes, the safety of doing venous stenting specifically in the office-based lab setting has been well documented. There are even FDA-approved stents designed just for veins. Now, they tend to be larger diameter than arterial stents.
So you need bigger balloons and stuff?
Yeah, you need the inventory to handle those larger sizes. And IVUS, again, is proving really valuable here, often more accurate than just venography for seeing how bad the stenosis really is.
Interesting. What else on the venous side?
The chapter suggests maybe in the future we might even see safe delivery of thrombolytics clot-busting drugs for iliac vein clots in the office setting. That's not standard yet, but maybe down the line.
Wow. Okay.
And also, vena cava filters the little filters to catch blood clots heading to the lungs they can be safely put in, and, importantly, taken out in OECs. This might actually improve retrieval rates, which is good because leaving them in long-term can sometimes cause problems.
So clearly not just arteries. What other random procedures might pop up in an OEC?
The chapter mentions port insertions, those little devices under the skin for easy IV access.
Right, for chemo or long-term antibiotics.
Exactly. Those can often be placed in an OEC as long as the patient isn't on blood thinners like Coumadin. That would make it too risky.
Okay. And the term venous center came up. Is that different from an OEC, or can they be combined?
They can actually be either. A dedicated venous center focuses mainly on superficial venous reflux, the cause of varicose veins.
Ah, the cosmetic side, mostly.
Well, often cosmetic, but also symptomatic relief. They do things like endovenous ablation using heat to close faulty veins, microphobectomy, sclerotherapy injections, foam, glue, all that stuff.
Right.
A venous center can be standalone, or it can be combined with an endovascular center. That combo can be really good for patients who might need treatment for both superficial and deeper vein problems, offers convenience, and maybe better coordinated care.
It really sounds like a comprehensive vascular center offers way more than just the procedures themselves. The chapter mentioned additional services. What falls under that?
Yeah, things like vascular medicine, which is super important, right? The ongoing medical management of patients with PAD and other vascular conditions.
Like managing risk factors.
Exactly. Helping patients quit smoking, manage weight, get into exercise programs. Plus, the specialists keep up with the latest medical therapies for hypertension, diabetes, high cholesterol, making sure patients get the best, most current care to prevent more problems.
That makes total sense. Treating the whole patient, not just the blockage. What else?
A wound care center is presented as an ideal collaboration.
Oh, that makes sense too. Fix the blood flow, then heal the wound.
Precisely. Patients can get revascularized in the OEC, then get specialized wound care right there or nearby.
Yeah.
This can really improve healing and potentially keep people out of the hospital just for wound management.
And working with podiatrists?
Yeah, collaboration with podiatry is key for limb salvage in patients with bad PAD and foot ulcers.
Yeah.
And lastly, the chapter discusses screening programs.
Screening for things like aneurysms?
Right. Abdominal aortic aneurysm, or AAA Medicare, actually pays for screening certain at-risk groups. Also screening for PA and carotid artery disease.
Is screening generally beneficial?
Well, it can definitely increase patient awareness and position the practice as proactive. But the chapter does note that the overall benefit of widespread screening for some conditions has been debated recently in the medical community, so it's not without controversy.
Okay, this gives us a really clear picture of the scope of what these centers do. Let's shift gears now. What actually goes into building and managing a center? If someone's thinking about opening an OEC, where do they even start?
The absolute first step is a rock-solid business plan.
Money first.
Well, yeah, you need to know if it's viable. It involves gathering data, understanding potential patient volume, doing a detailed financial analysis, estimating costs, projecting revenue. You really need to look at your current procedure volume that could move to an office setting and realistically project growth.
Calculating all the costs.
Oh, yeah. Initial capital expenses, ongoing costs for disposables, devices, labor, all of it. It's essential. For doctors new to this, the advice is usually build up your referral base and patient flow first before making that big OBL investment.
Okay, so the business plan looks good. What about the actual physical space, the building part?
Typically, the endovascular center needs to be physically connected to the existing office space for patient flow, staff interaction,
Right.
The chapter suggests somewhere in the range of 2,500 to 3,500 square feet, just for the lab and related areas.
What needs to fit in there?
You need a reception area, comfy pre-op and post-op recovery rooms, 1 or ideally 2 lead-lined procedure suites.
Lead-lined for radiation safety.
Exactly. Plus storage space, lots of it, a decontamination area for cleaning reusable stuff, maybe a manager's office, a central nurse's station.
And the procedure room size depends on the x-ray equipment.
Right. Depends if you're using a mobile C-arm or a fixed ceiling-mounted system. Fixed systems usually need bigger rooms. And if you're thinking about being an ASC or a hybrid ASC OBL, then there are often much stricter billing codes you have to follow, state and federal rules.
And then the big one, equipment. That must be a huge investment.
It certainly is. Getting financing is often a major hurdle initially. Most established labs buy their big equipment outright, but leasing options are often available too to help with upfront costs.
The chapter had lists, right? Tables 198.2 and 3.
Yeah. Detailed lists of what you need for the endovascular suite and a venous center. Key early choice is C-arm versus fixed imaging system. Depends on your expected case complexity budget.
Are modern C-arms good enough?
Oh yeah, modern C-arms with good vascular software offer excellent image quality for most office-based procedures. Fixed systems might be better for really complex cases or maybe very large patients where you need more X-ray power.
Buy new or used.
The chapter strongly recommends investing in new equipment if possible for reliability, functionality, latest tech, and definitely invest in high-quality ultrasound too. Using ultrasound guidance for vessel access significantly cuts down on complications. That's well established.
Okay, beyond the big machines, what about everyday supplies and medications? Must need a lot of stuff.
You really do. A fully stocked OEC needs a surprisingly wide array of disposables and a specific list of medications. Again, tables 198.4 and 5 in the chapter have detailed lists.
And managing all that inventory.
Yeah, the precise types and amounts depend on your case mix and volume, but implementing careful, efficient inventory control is absolutely vital for the financial health and smooth operation of the center. Can't run out of things, but can't overstock either.
And you need people to run it all. What kind of staffing does an OEC typically need?
It depends a bit on the size and the existing office staff, of course. But for the lab itself, you'll likely need dedicated roles.
Like?
A center manager, probably at least 2 RNs experienced in procedural work and monitoring, a skilled scrub tech, a qualified radiology tech, or an MA trained on the C-arm, and maybe another MA for pre-post-op areas and patient flow.
And anesthesia staff, if needed.
Right. If an anesthesiologist is involved, they usually bring their own dedicated support staff.
Data management is huge in healthcare now. What about electronic health records and picture archiving systems, EHR and PECS?
Absolutely essential. You need a robust, user-friendly EHR that integrates well with data management tools.
What should it track?
Everything. Patient demographics, history, risk factors, clinical findings, procedure details, outcomes. Ideally, it should also make it easy to participate in quality registries, like VQI.
And for daily operations?
The system needs to handle scheduling, inventory tracking, supply use, monitoring data, storing images, billing info, all while keeping clinical, business, and quality metrics linked. Transparency is key for reimbursement, improving quality.
And pay CS for the images?
Yep. A dedicated picture archiving and communication system is necessary for storing all those procedure images securely. For follow-up, quality assurance, legal reasons, ideally with secure remote access too. The chapter also lists key things that must be in the EHR documentation history, indication, procedure notes, follow-up, etc.
What about the nuts and bolts, biomedical and electrical stuff?
The procedure room needs enough outlets, adequate power, maybe even 220 volt for some devices. A reliable emergency generator is non-negotiable. Safety first.
Definitely.
All the medical equipment needs regular inspection, maintenance, service logs, and you need portable oxygen tanks and suction machines readily available for emergencies. Basic safety stuff.
And finally, for setting up, what about accreditation? Do OECs need it? Who provides it?
Well, currently, there isn't one single accrediting body just for OECs specifically.
Oh, really?
Yeah. But many OECs voluntarily seek accreditation anyway for quality and safety validation. They go through established organizations like the Joint Commission, AAHC, or AAASF.
Are those general accreditations good enough?
They help set baseline standards, definitely. But the chapter points out they don't always focus specifically on things unique to endovascular care, like procedure appropriateness or patient outcomes.
So there's a gap.
Kind of. To address that, the Society for Vascular Surgery, SVS, is actually developing its own specialized vascular center certification program that will likely put more emphasis on those procedure-specific quality metrics and outcomes. Keep an eye out for that.
Okay, so you've built a center, got the approvals, now the ongoing work, managing a center. Where does that start day to day?
First and foremost, meticulous management of medical records. It's paramount.
Keeping everything up to date in the EHR.
Exactly. All charts need to be complete, timely, meeting all legal and regulatory rules. History, physical, procedure notes, follow-up, everything. And remember, patients have a right to access their records. Good records are vital for care, legal protection, and getting paid accurately.
What about the operational side? The chapter mentioned having clear policies and procedures.
That's the operational backbone, really.
Mm.
A comprehensive P&P manual outlines best practices, how everything should be done clinically and administratively, the standards you follow for good outcomes and safety.
What should be in it?
It should define each procedure, list required equipment and supplies, give step-by-step descriptions. Crucially, it needs clear, regularly reviewed protocols for handling complications.
Right, what to do if something goes wrong.
Exactly, including emergency plans,
Hmm?
patient transfer procedures, and it has to reflect all the state and federal rules, plus any accreditation requirements.
Okay. Coding compliance and billing always sound like tricky areas in healthcare, lots of potential pitfalls.
Oh, absolutely. Both overcoding and undercoding can cause major legal and financial headaches,
And the rules change, right?
constantly,
Hmm.
especially for office-based procedures. So it's highly advisable to have a certified coder on staff or use a reputable external coding service. Regular audits, internal or external, are also strongly recommended to catch errors early and avoid big penalties.
And billing itself, in-house or outsourced.
Either can work. The key is timely claim submission and consistent follow-up on payments from insurers and patients. Clear policies on overdue bills, pre-authorizations, collecting copays. That's all essential for healthy cash flow and good patient relations.
With all this activity, data management must be a huge task for an OEC, more than just the EHR.
It really is. A good EHR is fundamental, yes. But you also need sophisticated software to manage office notes, images, meds, inventory, billing, outcomes data, and sending data securely to quality registry.
Needs to be integrated.
Ideally, yes. The data needs to be current, easily accessible, standardized for analysis and reporting. The chapter suggests that many generic EHRs might not be perfect for a specialized endovascular center's needs, might need something more tailored.
How does an OEC make sure it's actually providing high-quality care? That falls under quality control, right?
Exactly. Regular, systematic analysis of your data is key. Monthly meetings with doctors and staff to review patient feedback, any adverse events, any complications, that's crucial.
And if there is a problem.
You do a thorough root cause analysis. Figure out why it happened, put measures in place to stop it from happening again. Continuous improvement.
And comparing yourself to others.
Vital. Compare your outcomes and complication rates to national benchmarks from journals. Or if you're in a registry like VQI, compare yourself to other centers. It keeps standards high. And be aware, some states have mandatory reporting for serious complications in outpatient settings.
And how do you track if treatments are actually working for patients? That's outcome management.
Precisely. You have to diligently measure and track patient outcomes. It's critical for internal quality control, yes, but also for marketing and showing your value.
How do you use that data?
Well, initially, maybe you cite published literature, but as you grow, referring docs and patients will want to know your results. So you need systematic data collection and robust follow-up processes. Good outcomes become a powerful marketing tool.
And registries like VQI help with that.
Increasingly so.
Yeah.
Participating helps benchmark performance, and it can actually impact your reimbursement under programs like MIPs now, so it's becoming more and more important financially too.
Okay, despite best efforts, complications can happen. How does an OEC handle the management of complications?
Yeah, well, rates are generally low in well-run OECs. You absolutely must have clear written protocols ready for a wide range of potential issues.
Defining who does what.
Exactly. Roles, responsibilities, especially for emergencies and patient transfer to a full hospital if needed. Ideally a hospital where the surgeon has privileges.
Do you need a formal transfer agreement?
Not always legally required, but it's highly advisable to have a strong working relationship with a receiving hospital and maybe a collaborating surgeon, especially if the OEC physician isn't a board-certified vascular surgeon themselves.
And practice makes perfect.
Definitely. Regular mock drills, simulation exercises for major emergencies. That ensures everyone knows exactly what to do and can act quickly and effectively.
Makes sense. To keep the center thriving, good marketing is essential, right? How do OECs approach that?
Yeah, all successful OEC marketing is fundamentally local, and clear, consistent communication is absolutely key.
Easiest way to start.
Often the most cost-effective is actively engaging with local referring physicians. Share your good outcomes, highlight your strengths, be honest about limitations.
The 3 A's.
Still relevant. Availability be easy to reach, affability be pleasant to work with, and ability demonstrate your skills and results that build strong referral relationships. Marketing is ongoing, building on positive experiences, and maintaining a professional image everywhere, online and off, is critical.
What specific avenues for marketing does the chapter mention?
Direct contact with referring docs and their staff calls. Visits, very valuable. Informative brochures are cheap and effective. Sharing anonymized images of successful cases can showcase skills.
Newsletters, speaking gigs.
Yep, a regular newsletter for referrers. Speaking at local medical meetings, community events, maybe even educational sessions for specific practices. Local media newspapers, radio might feature new procedures.
What about online?
Absolutely essential today. A strong, up-to-date website is non-negotiable. Social media can be valuable too, especially if done professionally. And publishing any research you do in journals builds reputation.
Any ethical warnings?
Yes, the chapter stresses adhering to AMA advertising guidelines. Make only factual claims, avoid misleading statements, or creating unrealistic patient expectations. Be ethical.
Safety first. What about radiation safety specifics in an OEC?
Critical component. Rigorous precautions are needed to minimize exposure for patients, the operating team, everyone in the facility.
Like lead shielding.
Right, lead in walls, doors, ceiling. Plus, personal protective gear, lead aprons, thyroid shields, head covers, leaded glasses, maybe lead gloves if hands are near the beam, like in some access procedures.
And monitoring.
Regular safety testing of equipment and the room. Mandatory personal radiation badges, dosimeters for all potentially exposed staff. And if a doc works in both a hospital and an OEC, their total exposure needs careful tracking to stay within safe limits.
And finally, how do you know if patients are happy? Patient satisfaction.
Crucial for reputation and success. Using patient satisfaction surveys, like the sample in box 198.1, is a good way to systematically gather feedback.
What do patients typically like about OECs?
Often cited reasons are convenience, seeing familiar staff, avoiding the big hospital hassle, shorter visit times, easier scheduling, and getting results comparable to hospital procedures.
Any common complaints?
Maybe inadequate pain control during or after if conscious sedation isn't managed perfectly. The chapter does note a lack of standardized surveys specifically for OECs, though.
It sounds like constant evaluation is key. The chapter also mentioned physician evaluation of the center.
Yes, regular reviews, maybe quarterly, by all the involved physicians are important for good governance.
What should they review?
Marketing efforts, screening program effectiveness, patient outcomes data, complication rates, transfer rates, and definitely the financials. Keep formal minutes.
What about serious incidents?
An immediate meeting should happen to review the case, implement corrective actions, and regular review of profit and loss reports ensures financial viability.
And new devices.
Do a careful cost-benefit analysis before adopting anything new. Continually streamline processes for efficiency and patient comfort. Agree on device use among docs to manage inventory and costs. And crucially, never compromise patient care just to save money.
So looking ahead, what's the overall future outlook for these outpatient vascular centers based on the chapter?
This looks very optimistic. Poised for continued growth, really.
Why is that?
Healthcare payers are increasingly focused on efficiency, value-based care. OECs have shown they can be safe, cost-effective, patient-friendly for many procedures. The demand is expected to rise.
And payment models are pushing this.
Yeah, the shift towards value-based payments like MAC-RA and MIPS incentivizes high-quality, efficient care in lower-cost settings like OECs. Plus, patients increasingly prefer the convenience of outpatient services. Look at the success of ASCs in other fields.
Right.
The chapter even notes how OECs played a role during the pandemic, maintaining essential care when hospitals were strained. As more data comes out showing their value, they're likely to become the preferred place for treating an even wider range of peripheral arterial and venous diseases.
So to wrap up this incredibly informative deep dive, we've seen how these outpatient vascular centers have really emerged as a significant evolving part of healthcare. They're offering a wide range of procedures, both diagnostic and interventional, with a huge focus on safety, effectiveness, and efficiency.
Exactly. And this fundamental shift offers you, the listener, a really valuable new perspective on treatment options for vascular conditions. It could mean better access to specialized care, more convenience for you.
And that brings us to our final thought for you to mull over. As medical technology just keeps racing ahead, what other complex procedures might we realistically see move safely and effectively into the outpatient setting in the coming years? And what could the wider implications be for healthcare costs, for access to care, and for the individual patient experience? It's definitely a fascinating question to consider.
Yeah, it really is. And we certainly encourage you to explore any aspects of this that particularly sparked your interest. Maybe, look into the OECs in your own community or dig a bit deeper into the specific regulations in your state. There's a lot more to discover in this constantly changing field.